MRCPology channel for a quick review and understanding of the topic. Imagine a patient with advanced HIV who presents with a 2-week history of headache, fever, confusion, and a new right-sided weakness. Brain imaging shows multiple ring-enhancing lesions. In MRCP, that combination should immediately make you think of Toxoplasma encephalitis. Toxoplasma encephalitis is reactivation of latent Toxoplasma gondii infection in severe cellular immunosuppression. Classically, this occurs in patients with HIV when the CD4 count is below 100 cells per microliter. The key phrase to remember is advanced HIV plus multiple ring-enhancing brain lesions. Let's simplify the pathophysiology. A patient is infected with Toxoplasma gondii earlier in life. After the initial infection, the organism can persist as tissue cysts, especially in the brain and muscle. In an immunocompetent person, T-cell immunity keeps these cysts under control. But when cellular immunity becomes severely impaired, especially when the CD4 count falls below 100, that immune control is lost. So the sequence is prior infection, tissue cysts in the brain, severe T-cell immunosuppression, reactivation, tachyzoid proliferation, necrotizing abscesses. These abscesses often occur in the basal ganglia and at the corticomedullary junction. The lesions then cause surrounding oedema and mass effect. Clinically, this means compression of local brain tissue, disruption of neuronal networks, and sometimes raised intracranial pressure. That mechanism explains the symptoms. The presentation is usually subacute. Patients may develop fever and headache because of inflammation. Confusion or encephalopathy occurs because brain function is disrupted. Focal neurological deficits occur because the lesion affects a particular brain region. So a lesion affecting motor pathways may cause hemiparesis. A lesion affecting language areas may cause aphasia. Brainstem or deep lesions may produce cranial nerve signs or ataxia. Seizures are also common because irritated brain tissue becomes electrically unstable. Now pause here. This is the MRCP point. Toxoplasma encephalitis is not simply confusion in HIV. It is advanced HIV with confusion, focal neurology, seizures, or headache, together with ring-enhancing lesions on imaging. For diagnosis, MRI brain with contrast is the key investigation. It typically shows multiple ring-enhancing lesions with surrounding edema, often involving the basal ganglia. Serum Toxoplasma IgG is also useful. A positive IgG supports reactivation because it shows previous exposure. If Toxoplasma IgG is negative, Toxoplasma encephalitis becomes less likely. In a typical case, the diagnosis is often made empirically: compatible imaging, CD4 count below 100, and positive Toxoplasma IgG. Brain biopsy is not always needed at the beginning, but it becomes important if the imaging is atypical, if Toxoplasma IgG is negative, or if there is no clinical or radiological improvement after about 10 to 14 days of treatment. The main differential diagnosis is primary CNS lymphoma. Do not confuse these two in the exam. Toxoplasma encephalitis usually causes multiple ring-enhancing lesions, commonly in the basal ganglia. Primary CNS lymphoma is often solitary, deep, and periventricular, although there can be overlap. EBV PCR in the CSF may support the diagnosis of CNS lymphoma. Another important safety point: if there is mass effect or raised intracranial pressure, do not rush into lumbar puncture without appropriate imaging and assessment. Treatment is with pyrimethamine, sulfadiazine, and leucovorin for at least 6 weeks. Leucovorin is essential because pyrimethamine can cause bone marrow toxicity, and leucovorin helps protect against this. An alternative regimen is pyrimethamine, clindamycin, and leucovorin, especially if sulfadiazine cannot be used. Antiretroviral therapy should be started or optimized, but usually after acute antoxoplasma treatment has already been initiated to reduce the risk of immune reconstitution inflammatory syndrome. Prophylaxis is also very testable. Patients with HIV who are Toxoplasma IgG positive and have a CD4 count below 100 should receive prophylaxis with TMP-SMX, also called cotrimoxazole. Prophylaxis can usually be stopped when the CD4 count has risen above 200 for at least 3 months on effective ART. A quick recall question: a patient with HIV, CD4 count of 45, seizures, and multiple ring-enhancing basal ganglia lesions, what is the most likely diagnosis? Toxoplasma encephalitis. Second question: why is leucovorin given with pyrimethamine? To prevent pyrimethamine-induced bone marrow toxicity. Do subscribe to the channel for further videos.